One of the things we see pretty frequently is if somebody has imaging done of the cervical spine for any reason, it may be just not necessarily because they have a disc problem or a neck problem, just incidental imaging. You find that there's a lot of positive findings on the imaging. Those don't necessarily mean that you have disease. Disease in terms of symptoms. So there's a lot of radiographic findings that you may see which don't necessarily mean we need to do anything about them. They may just be incidental findings. If you had findings on an MRI or a cervical spine X-ray, but it wasn't bothering you at all, you may not need to do anything about it. So there are risk factors for the development of cervical disc disease. When we've studied these in the literature, there are reports about associations. So when you look at a population of people, an association with a factor leads you to conclude that this is probably associated. We usually don't have a direct causal relationship, just because that's a difficult thing to tease out, because there's many factors that influence them. But a lot of these factors that you can see, smoking, frequent loading, high-risk occupations, prior lumbar surgery. One of the things we see is the neck and the back. So the back, we talk by back, I'm referring to the lumbar spine. So from below the rib cage to the pelvis, that part of the spine is associated. If you have problems in the low back, you may also have problems in the neck. Other metabolic factors, factors like patients who need dialysis, and then things that you're born with that you don't have any control over is the size of the canal that you have. You may be born with a narrower canal. All that means is you have less reserve. So if something happens to your cervical spine, there's less reserve available, and you may develop symptoms more than somebody who has a wider canal. So natural history, cervical disc disease can give you symptoms. The punchline is that the majority of patients with cervical disc disease who have symptoms eventually will get better. It's usually the minority of patients who need to have something done in terms of something surgically done. So most of the conditions are self-limiting. Here you can see in this article that was written in 1987, it's of course worse if you have a history of injury. We do know you can have pre-existing conditions. Then when you have an injury, that brings to light some of the issues you had before. If you had never had the injury, we probably would not have known. Just like we talked about before, you may be having some signs if we took imaging, but if we have no reason to do that imaging, we may not see anything. So if you have an injury and then we take an X-ray or a CAT scan, then it brings to light what you previously had. So the things that can happen is you can have, when we talk about spondylosis, spondylosis just means the wear and tear that happens to the spine that causes things like bone spurs. And those bone spurs can then either impinge on nerves or cause pain. You can have the discs. The discs are the shock absorbers in between the vertebral bodies. You can have dysfunction of those discs. Those discs may come out and push on nerves and give you pain. We call that disc displacement. Radiculopathy means pain in the distribution of a nerve. And then a disc may come out and eventually ends up forming bone. And then that may be called a hard disc, and this may give you radiculopathy, which may be pain in the distribution of the nerve or weakness from pressure on the nerve. The worst, which is probably one of the things that can be silent, is what we call cervical spondylotic myelopathy. What that just means is degenerative conditions in the cervical spine or in the neck, putting pressure on the spinal cord, causing you to have spinal cord dysfunction. Because you may not have any symptoms in the neck, the only thing that you may present with is the symptoms that we see of spinal cord compression, which may be things like numbness in the hands, difficulty with balance, and fine motor tasks. So, presentation of the cervical spondylotic myelopathy. This results from direct mechanical compression of the spinal cord. There's associated vascular insufficiency. The spinal canal, which is at the center of the spine, carries the neurotissue. The neurotissue has blood vessels. So there's cerebrospinal fluid, neurotissue, and blood vessels. When you narrow the space available for blood flow to the neurotissue is reduced, and then you have signs of reduced blood flow to the neurotissue, which then presents in abnormal neurofunction. You may have fine motor control loss in the hands, and in later stages you may have bowel and bladder dysfunction. The important point about cervical myelopathy or myelopathy from compression in the neck is that it can be a painless condition. So what do we do when we are assessing somebody who has disease in the neck? We're interested in knowing if there's pain, where is it, how long has it been going on, and what is the nature of that pain. We want to look at and find out what type of motor function you have in the arms and in the legs, and we also want to see if you have any abnormal sensation. Do you have any numbness? Do you have any areas that you don't feel? And then one usually starts off with at least plain x-rays. Plain x-rays, two views, one from the front, one from the side, and then views with you moving your neck help us to see more of the dynamism that can happen. Sometimes you can have a problem which is only highlighted when we move your neck. If we took a static picture, you may not see anything. But when you move your neck, then we may see relative motion of some of the vertebral bodies amongst themselves, which is abnormal. And that then cues us in as to what the problem is. Other tests that can be done are nerve conduction tests. These are where we have needles put into the muscle groups, and then the nerves are tested, because the nerves which come from the spine innervate muscles. So they take sensory back to the brain, and the brain relays motor function. So you want to move your hand, the brain sends a signal, and the muscles that need to move your hand in space to get to where you want it to go execute that. The electrodiagnostic studies help us to find out, are the nerves conducting at the right speed? If the speed is not correct, where is the blockage? So for example, if you had carpal tunnel syndrome, we're able to see that it's at the last part of the nerve, so we know rather than looking up here, we are looking down here at the wrist. Some of the treatment modalities, rest, cervical collars. There's two main forms of collars that we can use. Rigid collars, we tend to use rigid collars for injuries. Soft collars can be used for comfort. The mainstay of treatment, the non-steroidal anti-inflammatory medications like Aleve, like meloxicam. Those help. Steroids, which can both be oral or epidural injected steroids, and physical therapy, which is one of the mainstays of treatment. When it comes to if these things don't work, then what next? If you have persistent or recurrent pain in the arm, if you have weakness associated with that, those are some of the reasons why you may need to have something done. If you do have conservative treatment done, but the conservative treatment, that means the non-operative things like the medications, the physical therapy, if those things don't help you, then you may need surgery. But just remember, it's usually the minority of patients who present with these things who end up needing surgery. Most people will be able to be treated non-operatively. The different types of surgeries that can be done for neck problems, you can approach the neck from the front, or you can approach the neck from the back, or you can do both. One of the common procedures that's done is if you have, for example, if you had a disc prolapse that's pushing on your spinal cord and giving you symptoms which has not responded to non-operative treatment, then you may need to have surgery from the front, either left-sided or right-sided approach, and do the decompression, which means taking whatever is pushing on the neuro tissue, taking it away, and then putting in either a spacer to do a fusion or an artificial disc, whichever the case may be. These are some examples you can see. Which is the pointer button? Amy?
The middle.
The middle one? Oh, yeah. So here you can see this is an MRI scan which shows this is the cervical spine here. This is the spinal cord as you see there. And you can see this is compression on the spinal cord. It's pretty severe. These are what we call the axial cuts, or the cuts that go across. And you can see how much compression there is right there on the spinal cord. And then that was treated with an approach from the front. The offending bone, the offending vertebral bodies were removed, and bone graft was placed as well as a plate. You can see this is the after, and if we go back, you can see that was before, and that's after. You can see now the spinal cord has room to breathe, and there's a plate up front. This is another patient who had compression there. This is from a disc. This is the disc right there. You can see the disc pushing on the spinal cord. You can see that again there. And then in this case, this was treated from the back, because you can go from the back, take the pressure off there, especially if you have these two levels separated by one. You can take the back off, and that's what we call a laminectomy and fusion. You can see this. These are multi-level. This is several levels of compression pressing on the spinal cord, and this was treated with what we call a laminoplasty. So laminoplasty is just simply like opening the door. Spinal cord is compressed. There's multiple areas where you make a cut, and you actually open up the lamina, which is the back part of the bone, and you put in a small plate which holds it open. So it's analogous to you opening a door and holding it open. So moving down, back pain. Back pain is one of the commonest complaints that we have in humankind. Afflicts everybody. Usually at some point in your life you've had back pain. Back pain could result from several factors. Some of them, it may just be myofascial, may be coming from muscles. Muscles are covered by fascia. It could be coming from degenerative disc disease, wear and tear changes to the discs in your back. It could be coming from the joints. The vertebral segment has two main joints. It has a fibrocartilaginous disc, which you usually see at the front, and then it has two facet joints, which are synovial joints, like your knees and hips, at the back. The facet joints are susceptible to developing arthritis. So just like you can have arthritis in the knee, you can have arthritis in the facet joints in the spine. You can have osteoporosis, which means loss of bone mass. That can cause you to have fractures because the bone is no longer strong enough to hold up the normal weight of the body, and then you develop pain from a fracture. You can have deformities. You can have what we call scoliosis, which is lateral curvature of the spine. You could have had this since you were young. As you get older, you're still prone to developing back pain, and this back pain may be associated then with a deformity, like you can see in this x-ray here. This is a deformity. This is a scoliosis. Other things, you may have a neoplasm. Neoplasm just means a new growth. So something growing in the spine that should not be there. You could have an infection. So one of the things that happens is, because our bodies are in motion, our bodies sustain wear and tear. So one of the universal things that happens to everybody is that our spines age. So as they age, they undergo degeneration. So looking at the spine, this is looking at a vertebral segment. This is a vertebral body here. These are the nerve roots back in here, which go within the spinal canal. These are the joints that we're talking about, the synovial joints. These are the facet joints back there. This is the intervertebral disc that is between the vertebral bodies, which acts as a shock absorber or cushion. The nerve roots exit at each level. They exit on the left and on the right. You can see one nerve root here exiting. This is exiting on the left. You have a similar nerve root exiting on the right side. These nerve roots go down to supply the muscles of both the upper extremities and the lower extremities. At the same time, these nerves also innervate the spine itself. And that's why sometimes if you have a problem here, the pain is referred to the region of the spine that this nerve supplies. So for example, if I have something pushing on the L5 nerve root, the nerve root which comes out under the pedicle of L5. This is the pedicle right here. That will give me pain in the distribution of that nerve. And that nerve, L5, goes down outside, on the outside of the leg. You can feel it all the way down and may go onto the top of the foot and into the toes. So when you come into the office and tell me that I have pain which shoots down my leg and it looks like it's in the L5 distribution, that's what we evaluate. So the intervertebral disc is made up of, there's an end plate above and an end plate below. The nucleus pulposus, which is the center of the disc, is a soft gelatinous material. When we mention disc herniations, what happens is this gelatinous material finds a crack in the covering of the disc and makes its way out and pushes on one of the neurostructures which gives us pain. That's what you'd call a disc prolapse. And when the disc comes out, it may still be within the fibers of the annulus. The annulus is just simply the covering, and it may cause this to bulge out. So you may have heard the term a disc bulge. All that means is the annulus here is bulging out. Instead of being where it is there, it bulges out. Bone spurs. Bone spurs are termed osteophytes. There are different stages that we have of degeneration. Stage 1 is where you have cracks. Stage 2 is where you have some of this making its way through. And you can see how you have progressive loss of height. And as this is the periosteum here, as this is pushed out, the periosteum forms bone. So the covering on bone forms bone. If you push that covering out, bone still continues to form, but the bone is no longer here because this is pushed out. So bone is laid out, and then you get bone spurs forming. This is a slide which shows you what the spine looks like. This is the cancellous bone here, and then this is the disc right there. And you can see this disc here looks much healthier than that disc there. And you can see now this is advanced degeneration. You can see the osteophyte formation, and you can see this is the spinal canal back in here, and you can see how the spinal canal gets narrowed because of the degenerative changes. So the spine has the 3-joint complex, the disc in front, which is made of fibrocartilage, and the 2 facet joints behind. So degenerative changes may affect different parts of the disc at different rates. So you may have, for example, the left side of the disc affected more than the right side, or you may have the facet joints affected more. So what that does is it gives you an asymmetric collapse, and that asymmetric collapse is going to end up giving you a scoliosis. So the scoliosis may not be one that we term the idiopathic scoliosis is what you have from childhood. This may be an acquired scoliosis due to the degenerative changes that happen as you age. So the factors that affect the aging spine: you have upright posture, you have mechanical forces, you have structural changes, spinal alignment, and paraspinal support. The spine does not stand in and of itself. It has muscles attached to it, and those muscles help to keep the spine upright. That's one of the reasons why physical therapy is so good. Physical therapy helps you to re-establish the muscle strength, the muscle tone that you need, that gives you the support you need to your spine. One of the things that pain does is pain causes you to go into muscle spasm. If you're in muscle spasm, that makes movement very painful. If you can work and break that cycle, some of that can be achieved through the modalities offered in physical therapy. So what happens when we develop lumbar spondylosis and stenosis? Kirkcaldy, Wallace, 1978, defined the degenerative cascade. It's basically a series of stages that the spine goes through that you see happening that describe the change from normal to degenerative. So once again, the facet joints, these are the facet joints. We're looking at the spine from the back here. This is the back. The spinous processes are what you can feel in the middle of your back. The facet joints have synovial membrane, they have a joint capsule, and typically they carry about 20% of the load that the spine carries. 80% of the load is carried by the disc in front. They undergo degenerative changes where you have synovial reaction, you have fibrillation of the articular cartilage. These are changes that also occur in joints. So like if you looked in the knee joint, you'd see the similar kind of thing happening. You can have erosion of the cartilage, and you can have osteophyte formation. Osteophytes are bone spurs. So degenerative cascade, just like we were looking at in the other slide, you see, you get annular tears. The annular tears are tears in the covering of the disc. They allow the gelatinous nucleus pulposus, which is the central disc, they allow it to come out into the outer layers of the annulus. When that happens, you can develop disc bulges. You can also develop internal disc disruption or resorption. And as you see here, you can see how that can herniate. So what happens is, as you lose the disc is made of fibrocartilage, which predominantly has water in it, and the water content helps to keep it, just like a tire is inflated, it helps to keep it maximally inflated. As we age, we lose water content in the disc. You get fissures, you get cracks, and what happens is this disc, which used to be that height, ends up collapsing. So the discs, as we age, get reduced in height. You have osteophyte formation, which is the bone spurs that we're talking about. The bone spurs can happen in front of the spine, and they can also happen at the back of the spine. The issue with them occurring in the back of the spine is you have the spinal canal, which has a set diameter. When you have things growing into the canal, you reduce the space available for the neuro tissue, for the nerves. And as that happens, you develop narrowing, or what we call stenosis. So you have facet degeneration. You can see that. The facet degeneration, because it's close to the nerve roots here, that facet degeneration can give you pain, and that pain is once again going to be referred to that nerve. So wherever that degeneration is, it can give you pain in the distribution of that nerve. So what do we see? That's kind of the pathophysiology of what happens. How does this translate into what we see? So we see degenerative disc disease, stenosis, which means narrowing. We also see what we call spondylolisthesis. So spondylolisthesis simply means slipping. So you have spondy, which is spine, and listhesis, which is slip. So just like the analogy that the disc is like a tire, so just imagine you had a fully inflated tire. If you reduce that pressure by a half, and you have two things sitting on top, when it's tight here, it's stable. If you reduce it, it's more mobile. And because of that, you may have a slip develop. So how does this present? So this may cause you to have back pain. Axial back pain just means pain in the back. It's not necessarily going anywhere, but it's just painful. It may give you radiculopathy, just like we talked about in the neck. This pain may be referred and go down your legs. It may go down the back, it may go down the front. It just depends upon where the pain is originating from. So when you tell us, when you come to the office and you tell us, my pain is here, we look at that geographical distribution of the pain, and then we look at the imaging to tally the two to make a diagnosis. When the nerves don't have enough blood supply because of the narrowing, you may get what we call activity associated pain. You're sitting here, you feel fine. You get up and walk, it's painful. You sit down and rest, it goes away. That's a condition we call neurogenic claudication. and is likely to be associated with stenosis or narrowing in the spine. The narrowing is not of such a degree that it gives you pain at rest, but as you increase your activity, the nerves require more oxygenation. Because their blood supply is limited, that's when you develop pain. So stenosis, this is narrowing that happens. So this is an axial. So we were looking at the spine from the side. This is like we made a cut across and we're looking at the spine. This is the front here, this is the back. This is the right side and that's the left side. So the spinal canal sits right in there. And stenosis or narrowing happens for a variety of reasons. Bone spurs form which encroach on the narrow canal. Because of the instability that we talked about, like the tire that's been deflated, there's instability. So the ligaments that are holding the spine try to counter that, so they get thicker. They say, this is too much motion, we want to stop it. So the ligaments get thicker. But once again, the ligaments are within a closed space. So the ligaments getting bigger just makes less space available for the nerve roots. So you can see stenosis contributed by the facet arthropathy. You have thickening of the ligaments, and you have osteophyte formation, which are bone spurs. So all of these things, if they don't give you any symptoms, you don't necessarily need to do anything about them. But if these conditions are giving you symptoms and the symptoms are not responding to non-operative treatment modalities, then that's one of the indications you may need to have something done. So disc herniation commonly occurs in the 3rd to 5th decade. It's not completely out, but it's not as common in the elderly. And it's when you have the nucleus, which is, as we said, the gelatinous central part of the disc, because of the tears that happen due to the degenerative wear and tear changes, and then you have some of this finding its way out. Sometimes a patient may tell you, I just woke up and I had this horrible pain. Other times they may say, I was bending over, I was lifting something and I felt a pop in my back and then searing pain down my leg. Either way, we don't know what exactly causes it. We know there's associated things. If you have an annular tear and then you do a heavy lifting, you try to lift 200 pounds, you bend and twist, that may do it. Other times it may be just, I woke up this morning and that's what happened. So we talked about spondylolisthesis, which is the slippage, where because you've lost disc height here, it's almost like you have loose guy ropes. So when the disc is expanded, when it has its full water content, it holds things in a stable condition. If you lose disc height, it becomes more mobile. If you have the facet joints are at the back. Remember, they also can undergo degeneration. The facet joints typically are stops. They stop the spine from sliding forwards. If the facet joints also undergo degeneration, they may allow the spine to slip forwards. As it slips forwards, because the nerves are tethered, you may have stretching of the nerves, which gives you pain down the legs, or alternatively you may have nerves which are crossing here. If you have this type of arrangement and you move it like this, there's less space available. So this can also cause stenosis or narrowing. So this is the spondylolisthesis and slip. What contributes to it is loss of disc height, facet degeneration, capsular laxity, and segmental. Segmental means just a vertebral segment consists of two vertebral bodies separated by a disc. So if you have instability. So as you see, just like we've been talking about, this is the nerve root here. You can see what happens as this slips forward, that nerve root can get pinched. So going back to our lumbar degeneration, indications for surgical management. Any of these that present, so just simply having this on an X-ray or an MRI doesn't necessarily mean that you need to have anything done. It's if this is causing you symptoms and you've been through treatment modalities that have not helped, that's when you consider surgical intervention. So moving on to osteoporosis. So osteoporosis is a disease of increased skeletal fragility accompanied by low bone mineral density and microarchitectural deterioration. So what you're having is you have normal bone which has these interconnections, as you can see here, and when there's osteoporosis you have less bone and less connections. That's basically what it means. So as we age, so you tend to get to your peak bone mass earlier on in life, and once you get to your peak bone mass, as you continue to age, you lose bone mass. So it's a balance between how much you replete and how much you lose. The more you lose, if the balance is more negative, you tend to lose more bone. As you lose more bone, that's when you develop osteoporosis. So there's two basic forms. There's a primary, cumulative loss from age and the changes, hormonal changes, and then secondary osteoporosis, which is due to an associated medical condition. So it is a significant problem. It affects more than 10 million Americans, and the estimate is 14 million by the year 2020. Osteoporosis is important to us because it's a significant cause of spine fractures, significant cause of other orthopedic fractures like hip. You can also have distal radius, that's of the bones in the arm, wrist fractures as well. So looking, this was from 2007, they estimated about 547,000 vertebral compression fractures. Other fractures, as we talked about, is fractures of the hip, wrist, pelvis, and others. So this was just an estimate as to how much osteoporosis, the economic burden. The most important from our standpoint is what happens when you get a vertebral compression fracture. There is increased mortality, meaning when they looked at same age patients, those who had vertebral compression fractures and those who didn't, there was a higher mortality rate in those who had fractures. The most important thing is once you get a fracture, there's a 2.5-fold risk of developing a subsequent fracture. So osteoporotic fractures, they cause pain, they cause loss of height. Sometimes you see the progressive forward bending of the spine as people age. Sometimes that's associated with multiple vertebral compression fractures that happen in succession. Kyphosis, which is the forward bending of the spine, causes problems. It restricts the lungs from expanding. It also can, in severe cases, can cause compression on the abdominal contents, leading to poor appetite and other issues. The most significant issue with the vertebral compression fractures is the risk of developing another fracture. And one of the things in the definition of osteoporosis is not only the reduced bone mass and altered architecture. If you do have a vertebral compression fracture, an osteoporotic, that's a definition of you. Once you have it, we know that you're osteoporotic. So peak bone mass, just like we said, you achieve it when you're earlier on in life, and then as you go forwards, your bone mass keeps on reducing. Greatest determinant is heredity. Estrogen is necessary for peak bone mass, and then there's of course other factors that contribute. Nutrition, balanced nutrition, physical activity, regular exercise is associated with maintenance of bone mass. Smoking is one of the factors that leads to reduction in bone mass. And there's been a triad that has been described in female athletes: menstrual dysfunction, low bone mineral density, and low energy availability. This is just a slide that shows the interaction between calcium and vitamin D. It is important to have a daily intake of calcium and vitamin D. They are important in the maintenance of bone mass. There are arguments currently in the literature into how much is absolutely necessary, but I would say some degree of calcium and some degree of vitamin D is beneficial to you maintaining your bone mass. Bone biomechanics. So the ultimate strength of bone is determined by the amount of cortical bone, which is the bone that's on the outside, and the trabecular bone is the bone marrow or the bone on the inside. So as you lose bone mass, the body attempts to correct this by increasing the size of the bone. The cortical bone then carries more of the load. As you're younger, the trabecular bone carries more load. So one of the things that you see is regular exercise helps, because the repetitive loading stimulates the osteocytes or the bone cells to maintain the bone mass. So going back to the vertebral compression fractures, they do cause pain, they cause reduction in height. So when you look at an X-ray with a vertebral compression fracture, previously it looks like a rectangle, and then it looks more like a collapsed rectangle. So the greatest risk, we said, from the development of a vertebral compression fracture is the risk of having another fracture. When the fracture reduces the vital capacity or the capacity of the lungs, that reduces your pulmonary function or ability to breathe, and then the pressure in the abdominal cavity leads to you not being able to fill your tummy, so to speak, and leads to you having poor nutrition. So what's a T-score? So the T-score is just the number of standard deviations of the bone mineral density above or below a mean. Bone mineral density can be measured. There are scanners that you go into the scanner. They scan various parts. They can scan your spine. They can scan your distal radius. They can scan your calcaneus in the foot, and they can use those, match them against the standards to find out what your bone mass is. That helps us to know the whole idea. The goal of that is prevention. If you find that you have a low bone mass, you want to be doing things to try to preserve the bone mass that you have. So this is screening. So dual X-ray absorptiometry. Who should be screened? Women 65 years or older, bone mineral density at or below a treatment threshold, and if you have risk factors for the development of that we're going to look at. So key risk factors in white women is maternal history, any fracture after the age of 50, poor health, things like hyperthyroidism. The thyroid gland is in the neck, responsible for hormones. There are medications that can result in you having low bone mass, like anticonvulsant drugs. Immobilization, prolonged immobilization causes you to lose bone mass. You also lose muscle mass as well. That's why if you've ever had a patient who had a prolonged hospital stay, when you see them before they went in hospital and when they come out, they've usually lost a lot of weight. It's because if you lie in bed and you don't move, don't get up, you tend to lose bone mass. You also lose muscle mass. Risk factors for osteoporosis, again, early menopause, poor nutrition, sedentary lifestyle, a family history, and scoliosis, and race as well. Prevention, once again, we're going back to the calcium and vitamin D. In terms of the amounts, calcium, vitamin D, regular weight bearing, exercise, avoidance of smoking, avoidance of excessive alcohol, and then there's medications which are associated with osteoporosis. One of the key ones is sometimes we have no control over it, but patients who require prolonged steroids. Prolonged steroids do cause you to lose your bone mass and to develop osteoporosis. Looking at, there is a problem. Once you have an osteoporotic fracture, you're at high risk for developing another. So the whole goal is prevention better than cure. So fall prevention, balance and posture and exercise training. The various forms of treatment options, the ones that you've probably heard about are the anti-resorptives, that's like the Fosamax, Actonel, all those that you see there. There are side effects from those. I don't regularly prescribe these. We usually have the patients see their primary care physicians or see an endocrinologist with these, because they are associated with, you need to look at the whole patient. You need to know their hormone profile. There's tests that you need to check up on these. It's not just simply prescribing them. And it's time for questions. Thank you very much. Yeah.
I was taking, I see estrogen here.
Mm-hmm.
And I was taking it from the age 56 when I had a hysterectomy until 70. And then the OBGYN said I was taking too much. And he kept cutting it in half to where I'm not taking it at age 73. So that kind of contributes to the there.
Well, the estrogens are it's a balance, and probably get the answer from asking the OBGYN. But the issue is the estrogens, you look at the possible side effects. So there's always a risk-benefit analysis that you have to go through. If we go back, probably didn't have it in here, but the estrogen is associated with some side effects. So it's not that you get that. It does help you with bone mass, but then the concern is, what possible side effects do I have? So that's why providers are usually concerned about prolonged effects. Yes?
I had the same thing, and I thought it was interesting because I've been taking estrogen since, what, 30, when I had everything wiped out. And so when I went in June, she says, well, you're still taking that? And I said, well, yeah. And she says, well, you're not supposed to be taking it. I says, why not? Nothing seems to be going wrong. And she says, oh, well, you could possibly develop cancer. And I'm like, so could anybody else, and I don't have it in my family, so what's your point? Well, you don't need it. I says, what? You're trying to say I don't need sex anymore? Is that what you're saying? And I says, you know, this is crazy. She says, well, I want you to stop taking that and try this cream. And I'm like, okay, I'll play your game. We'll do it. We'll see what happens. So now I've got this problem. And I thought it was very interesting. She came up with the same thing I came up with. You know, if this estrogen is not hurting you and you're taking it, why not keep taking it? Is there a reason why you shouldn't?
Well, the concern is the possible side effects. So so there's benefit and there's risk.
You flip a coin on that, you walk across the street, you got a chance of getting hit.
So I think one of the things that one needs to do is to sit down and say, what are we achieving with this, and what are the possible issues we could come up with? And then the patient makes an informed choice as to which way they would like to go.
Is there any link between obesity and back problems?
That's a loaded one.
Yeah.
So what we know is if you have a back problem and you're overweight, if you lose weight, there is a high chance that your back problem is going to improve. Intuitively, when you think about it, the back was made to only carry a certain amount of weight. If you excessively load the spine, there is the possibility that it won't hold up. We have seen in spine surgery, we know above a certain amount of either body mass index or patient weight, we see a higher incidence of complications. So if somebody comes with a problem, you observe more complications in the patient who is obese. So one of the things that you try, sometimes it may require a bariatric consult. If the patient can get weight down, sometimes that may be the primary thing you have to do. Let me just say, patient weighs 500 pounds and has back pain. If they don't have anything that's life-threatening in terms of the back, there isn't a disc that's causing loss of bowel or bladder function. If the patient could have a consult, if they were a candidate for gastric bypass, let's just say, if they were able to lose 200 pounds, you may find that the symptoms that they've had, if it was just simply axial back pain, may improve.
I do yoga on a regular basis. It involves a lot of bending,
Mhm.
back, sideward, backward. Is it good or bad?
If the exercise is not causing you pain and is helping you to maintain your range of motion, helping you to maintain your strength, it's a good thing. If you're pretty stiff and you can't even bend over and you try a yoga pose, probably that's not a good idea. But I think if it's something that you've worked yourself into and you do regularly, I think it's a good thing.
It improves back health by doing yoga?
It tones the muscles. It's like the modality of physical therapy. So the spine does not stand alone. The spine has muscles attached to it. The more that those muscles are in tone, the more that those muscles work well, the better the spine functions. Yeah. Yes?
Spinal stenosis, if it is hereditary, are there things, does it continue to get more narrow as a person ages?
So what happens is the reserve that you have, if you have congenital stenosis, so you start off, so let's say there's two people. Someone has a canal that size and someone has a canal that size. If both of them develop the same bone spur, the bone spur in that canal is less of a contributor to stenosis than in that canal. So what happens is they just have less reserve. So they may become symptomatic sooner. We don't really have a hard and fast rule, because there's people who you look at the MRI and you're like, wow, that looks tight. They have absolutely no symptoms. And then you have one where you look and you think, oh, maybe they have some reserve, but then they are the ones with the symptoms. So there isn't a real correlation between the two, but you just know if you start off with a narrower canal, you have less reserve. It doesn't necessarily mean that you will develop symptoms. So
How about posture? So like sleeping with the tummy versus back versus side, and sitting. Are there anything that we should be doing to prevent that?
For pretty much, if you're comfortable when you're sleeping, that's not a problem. For people who have existing back problems, there are some things that we recommend. If you, for example, have a neck problem, one of the things that many pillows do is it forces you into kyphosis. So if when we examine you, if you flex forwards and that gives you discomfort, sleeping with several pillows is probably not a good idea.
Good idea?
Is probably not a good idea.
Okay.
If you know when you flex your neck forwards, it gives you discomfort. Because what it's going to do is, you sleep for several hours, is it's going to make you feel, you wake up and probably feel uncomfortable. There isn't anything that I've seen in the literature talking about, like sleeping positions and so on. But there's things that you can do to improve your comfort. If you have tight hamstrings, if you sleep and put a pillow under your knees, it's going to make you more comfortable. If you put a small pillow in the small of your back, it's the lordosis, that's the forward bending of the lumbar spine. Accentuating that makes you more comfortable. If you have tight hips, if you sleep on your tummy, that's going to help you stretch your hips out.
The physical therapist, she told that you should not sleep with tummy down, it's going to hurt the back. Is that true or she is wrong? She said you should not sleep with tummy, on tummy.
I don't know why. I don't know why, unless you have a sleep problem that's going to cause you maybe to not be able to breathe properly. From my standpoint, some people don't tolerate sleeping on their tummy. Some people don't like sleeping on their back. Some people like sleeping on their sides. Those are personal preferences that you have. But as a rule, saying that you don't sleep on the tummy, I don't have any evidence.
How about the matrix type?
I beg your pardon?
How about the type of the matrix? Like extra fair pillow, does that have an effect?
I would say not really. Some, I mean, this, you have to qualify the statement. Let's assume that you're comfortable, you don't have a pre-existing back problem, and you're just looking for a mattress. I would say whichever mattress is comfortable for you is the one you get. If you're looking at achieving a specific goal, like we talked about, you need your hips stretched out, or you need your knees, you have knee flexion contractures and so on. There are things that you can do with a bed to make you more comfortable. That's when these beds, like the mattress which has the memory foam and so on, that's where that could be helpful. If you have issues with your neck, you can't flex forwards, or if you, I would say, let's take the example. There's a condition which is called ankylosing spondylitis. So basically what that means is the spine is completely stiff. It's like a bone, one bone. Your spine is stiff. So that person needs a mattress that's going to conform to their pre-existing spine. So if your spine is curved forwards like this, and you lie on a regular bed, your head is going to be up in the air, and you're going to have a pressure sore because all the pressure on your back is concentrated on that area. So you need a mattress which is going to conform to your shape. So you may need a memory foam. If that's not enough, you may need a special bed which has an ability to raise up like a recliner, so that when you lie down, you have your weight spread evenly. So it's difficult to make generalizations about this mattress, that mattress. It's an individualized case, I would say. Yes.
I have osteoporosis.
Yes.
And I've taken two reclass treatments so far. When I took the first one, they had said, "Do you want this little pamphlet on osteoporosis?" I said, "Sure." First thing it said was, "Here's some facts about your postmenopausal osteoporosis."
Well, probably I think they needed to see who they were giving it to.
There's not enough of it.
Yes.
You mentioned here on the one slide about scoliosis being a risk factor for osteoporosis in these females.
Yes.
Is there any literature or anything for idiopathic scoliosis being a risk factor for any of these other issues you talked about, like stenosis or degeneration of the fascia? Is there any type of risk factors that idiopathic scoliosis leads to?
Well, not really. The association between the female osteoporosis and idiopathic scoliosis, yes, but the rest, apart from, because what happens to the people with idiopathic scoliosis is they're still prone to developing any of these conditions that we've talked about. And the only difference is if they are in balance. So as long as they have a balanced curve, those issues are not a problem. The problem with the scoliosis is it compounds the problem if you have instability. So for example, you have what somebody would have at L4-5, which is in the low back. Because you have the addition of the curve up on top, that can cause the spondylolisthesis or the slip to progress if they're out of balance. So we know that once the scoliosis is out of balance, usually if they're coming to see us for a problem, until we can get them back in balance, the problem usually gets worse. So if you have a balanced curve, I would not say any, but if the curve is unbalanced, that's where you have, these problems are magnified.
When you say unbalanced, you mean like a curve, two curves?
If the two curves are similar and the patient is able to stand up straight, But if they're off like this or off like this, then that is, any of these conditions get magnified by that. Yes. All right.
What are your recommendations in terms of making back more healthy?
I would say try to keep fit, regular exercise, stop smoking or don't start smoking. I would say make sure you know what your status is. Are you osteoporotic or not? If so, are you taking calcium? Are you taking vitamin D? And avoid, I would say avoid, there's some things that you do. If you have, for example, if you like working out, there's things that you do. If you have worked up, like people who do powerlifting, I give an example. If somebody has worked themselves up and they've got to a point where they can powerlift 150 pounds, that's different from somebody who says, I'm going to the gym and I'm going to see what I can do. Let me see if I can do this 150 pounds. That's probably a bad thing to do. That's what I would say.
And one last question about the idiopathic scoliosis. When I was diagnosed many years ago, it was explained to me idiopathic means they didn't have any cause.
Yes.
Is there any research or anything that would suggest that maybe someone's trying to find out what causes scoliosis?
Well, they're trying to look, they've been looking at trying to identify if there's a specific gene or genes involved. They haven't really come out with anything super conclusive about it, because what they were trying to do is so for the idiopathic scoliosis we're talking about, because we know that there's other spine deformities that we know, for example, as you develop, if you have failure of the vertebral segments to form properly, that can give you curves. If you have things like a syrinx or something in the spinal cord, that can give you the scoliosis. So if all those other things have been excluded from the equation and we don't really know if there's anything else causing the curve and it's just a curve in and of itself, we don't yet know definitively why it's there.
A lot of times it seems like they don't even look into some of those stages, right? If you're 16 or 14, you have scoliosis, they call it idiopathic scoliosis.
Well, usually...
I don't ever remember anyone even trying to find out what caused mine. They just said, you got idiopathic scoliosis. It's like, okay.
Well, there's curve patterns that suggest that. So there's usually you get the investigations, the more investigations when your curve pattern is one of the rarer ones. Yeah. So, all right.
Does fusion causes future more problems? Surgery and they make fusion. How risky is this for the next levels of your spine?
So several studies have been done investigating that. They've looked at, so what they looked at was, they looked at a group of patients similar age who underwent fusion, and they looked at those who did not undergo fusion, and they followed them forwards. They looked at people in the fusion group who needed other procedures, who developed what we call adjacent level degeneration, meaning degeneration above or below a fusion. And then they looked at the other group who continued to develop through this regular cascade, developed other areas of degeneration. And they did not really find a significant difference when they looked at the neck in adjacent segment degeneration. So it is thought somebody who's going to develop a symptomatic degenerative condition is likely to develop that at other levels, just from the natural history of the disease. So fusion in and of itself does not necessarily lead to that. However, having said that, there's certain things that you can do during the fusion that can predispose. For example, in the neck, if you put a plate on the spine and the plate encroaches on the next level, the chances of that level undergoing degeneration are higher as compared to if the plate is a shorter plate. So that's been documented, that's been written up. So when a fusion is done in the cervical spine, the plate you put on is the shortest plate spanning the segment to avoid any adjacent segment degeneration. So I would say that's debatable. Yes?
Okay, so like I've got this little degenerative stuff going on down here on the spine. So say you put a little piece of metal or plate in there type of thing. Now, like in my leg type of thing, when that was busted up, they put stuff in and the bone just goes right over it. Just covers it right up. Would that happen in the spine?
It depends how they do the
other
procedure.
Thing is, I do a lot of protein, and I've got my calcium and I've got my vitamins. I've got lots of vitamins like this. But is there? What are the chances? Are there that it could grow over? That it could be okay?
So when you go back in and you do a revision or you do removal of instrumentation, there's usually some amount of bone that grows over the instrumentation.
Okay.
It depends on what type of fusion technique was done. Because when you do a fusion, you usually put bone graft there. So where you place the bone graft affects where it grows. So if you put a lot of bone graft, you're going to get a lot of bone formation. If you use adjuncts to formation of bone, like bone morphogenetic protein, it tends to form a lot of bone. So you may have more bone there. The question is if you put it in an area where it's away from the nerves and your primary goal is to have the two bones joined together, that's what you want. You actually want to see bone, because when you see bone between the two vertebral bodies, you know that the operation has been a success.
But when you got a nerve involved there,
then it's not a success. So, yes. On inversion therapy. So that's basically traction. So when you have degenerative conditions like we've talked about, the spine collapses because of gravity. When you do inversion, all you're doing is temporarily suspending gravity. So when the inversion is over, gravity comes back. All right, thank you very much. All right.